Welcome back, everybody. My name is Paul Conway, and I serve as Chair of Policy and Global Affairs for the American Association of Kidney Patients. And you're now going to listen to the second session of our Under the Dome series. We've done this series for about 10 years at each of our meetings so that people out there across the United States, patients and caregivers and families, can hear from some of the folks inside Washington, D.C. that are fighting barriers and obstacles that prevent you from getting access to the innovations that we've invested so much time in working for. So this year we've titled this part of the session, Issues and Policies Impacting Patients' Consumer Choice and Access to Treatments. And it's very interesting. What we're concerned about is the lack of coordination and focus by the federal government on the pipeline of regulatory approval to payment to patient access. And when do doctors actually get to add that new tool, that new innovation to the toolbox so that patients are getting the optimal care, all patients? In the session today, we'll take a look at a number of different issues, including payment for renal physicians. Our first guest is a very good friend, Rob Blaser. Rob has served as the head of government affairs for the Renal Physicians Association for a very long time. He has an absolute encyclopedic knowledge of what it takes to make certain that doctors are paid fairly and that innovations are brought forward for patients with those frontline folks that take care of us each day. Rob has won several different awards, and we're proud of the fact that he has won our President's Award at AAKP. Rob, go right ahead.
Thank you, Paul, for the kind introduction, and thank AAKP for the invite. As always, it's wonderful to speak to this group, and I'm ready to get started. So I'm going to be talking about priority issues for nephrology for the fall. And this is, of course, from the perspective of the Renal Physicians Association, my employer. We represent community nephrologists nationwide. So what we're going to be talking about today are issues important for RPA, and we are socioeconomically oriented. So, of course, Medicare payment reform, and that's both for 2024 and to try to do some long-term system restructuring because there are problems with the underlying foundation for Medicare physician payment. We'll also be discussing funding for extension of the Advanced Alternate Payment Model bonus. These are the kidney payment models that nephrologists participate in. There's a bonus for participating in them to help underwrite the cost of doing that, and we want to get that extended. A bill eliminating cuts in vascular access care. Talk more about that in detail in a moment. The ESRD prospective payment system rulemaking cycle that happened just recently, and we'll have a slide on that. Living organ donation bill, the omnibus kidney disease legislation, and there was great news in July. There was a big transplant network bill that passed, so we're going to review that as well. So Medicare Part B payment reform is really in a bad place right now. The status quo is a conversion factor cut for 2024, and the conversion factor is the multiplier in the Medicare fee schedule formula where medicine gets a pay raise or a pay cut every year, and it's been cut again for 2024, proposed to have a 3.3% cut, and this is the fourth year in the row that has happened. The positive news is that there's a lot more discussion about using the Medicare Economic Index as a way to determine Medicare physician payment, so that might provide some relief. There was a bill introduced on this in April that would provide relief based on that. It would provide an inflationary update, which was positive 3.8% for this year. So instead of if this were extended for next year, instead of a 3.3% cut, there would be a 3.8% payment increase. Now, the thing is, this actual bill probably isn't going to pass, but it's one of those messaging kind of bills that's out there that will help move along this issue. Advocacy isn't necessarily a one-year effort, so this is something that hopefully would happen in the next year or two. There was a hearing in June in the House Energy and Commerce Oversight and Investigations Subcommittee where this was all discussed. And additionally, there's a House Dear Colleague letter on the issue signed by 100 members of the House. So the positive part of this is that there's obviously a recognition on the part of members of the House that they've got to do something about physician payment. So that's good news. So we're also going to talk about the extension of the Advanced Alternate Payment Model bonus. The payment model bonus is for participants in the Advanced Alternate Payment Models. This was scheduled to end with the 2022 performance year for 2024 payments. There's a 2-year lag in all of these programs, so that's how that works. Last year's omnibus bill, this is the big bill at the end of the year that always gets passed that fixes things in Medicare. It extended the bonus for the 2023 performance year, but at a reduced rate of 3.5%, down from the previously established 5%. So there is a bill out there now as of late July, HR 5013, the Value in Healthcare Act of 2023, and this would restore the full 5% bonus for qualified APM participation for 2 years. So that would be great news if that passed. And this issue is particularly important for nephrology, given the specialty's ties to Medicare and how commonly the kidney payment models are being used. So there are also ongoing cuts in vascular access care. Right now, we're in the midst of this 4-year transition that would reduce the values for in-office procedures by 20%, 5% per year. Now, in fairness to CMS, this is due to updates in clinical pricing inputs and data that hadn't been revised in 20 years, so they were overdue. And it's also beneficial to primary care. So it's one of those things that's hard to argue against, hard to advocate against, but it's happening because of the way the formula works. There's budget neutrality in the Medicare fee schedule. So if something gets increased payment, something else has to have decreased payment, and that's why this is happening. And unfortunately, it's extremely damaging to in-office vascular access care. So if you're getting your fistulas and that kind of work done in the in-office setting, the payment for those services is going down a lot. So that's obviously a bad thing, because I don't think the government realizes how vitally important that care is to dialysis patients. There is a bill out there on this, HR 3674, the Providing Relief and Stability for Medicare Patients Act of 2023, and this would mitigate cuts to in-office procedures such as for vascular access care by increasing non-facility practice expense RVUs. So we're hoping that this bill will, again, this is another one of those bills I don't know that's going to be passed, but it's one that's kind of messaging out there, and it raises the profile of the issue in Congress and with policymakers. So with regard to ESRD PPS dialysis facility payment, the proposed rule came out this summer, and it did provide a positive 1.6% increase. So, relative to physician payment, that's kind of a good news. But unfortunately, the national healthcare inflation rate is about 6%. So while this is positive, the figure is considered to be low considering the impact of COVID and the substantial increase in labor costs. It's really hard to hire nurses, any qualified staff to work in dialysis facilities. So labor costs have just exploded over the last couple of years. And also the payment rate doesn't allow for innovation. So that's why a lot of the technologies and a lot of the way things have been done in dialysis facilities are fairly unchanged over the last 20 years. And that's why, because the payment system doesn't allow for innovation. And, it's interesting, given that the nation's ESRD population has the highest percentage of African American, Hispanic, Indigenous, and low-income subsidy persons in Medicare, the administration's really trying hard to promote health equity. However, it doesn't seem to be applying it to the ESRD prospective payment system. So RPA made comments on this last month where we strongly urge CMS to consider ESRD prospective payment system in the context of what they're trying to do with regard to health equity. So the living organ donation bill, this is the same bill that's been out for the last couple of Congresses. AAKP is strongly supportive of this. It would address barriers to organ donation by essentially revising insurance that prohibits the denial of coverage or an increase in insurance premiums for living organ donors, designates donation surgery as a serious health condition for the purposes of the Family Medical Leave Act, and requires HHS to update educational materials. The bill was introduced in April and has a whole lot of momentum. This is one of those situations where the congressional staff are very involved in championing this, and that's a great aid to a bill like this. The House version currently has 120 co-sponsors, and the Senate version has 28. And very importantly, the Congressional Budget Office laid out a tentative score, which is a cost estimate that's reported to be zero. So this is all great news. So there's reasons to feel optimistic about the living organ donor bill. So hopefully that'll get across the goal line by the end of the year. And then there's the Community CKD bill. The bill's called the Chronic Kidney Disease Improvement in Research and Treatment Act. It was introduced in July. It increases access to the Medicare Kidney Disease Education Benefit, the KDE benefit, expands the wellness benefit to include KDE screening, addresses the kidney care workforce crisis, which we've already touched on, promotes innovation, guarantees access to Medigap policies, and reinstates dialysis services as subject to the Medicare Advantage adequacy, which is time and distance requirements. This is another one of those bills where the passage is unlikely, but it serves as a platform for individual provisions. And we're hoping things like the kidney disease education benefit provisions would get plucked out and put in whatever bill happens at the end of the year, and also the provision with regard to the kidney care workforce, which would provide loan forgiveness for nephrologists working in rural areas in addition to some other aspects of that provision. And the positive news, praise the Lord and pass the liquor, the Transplant Network bill was enacted in April. You can see the name of the bill there. This is really a remarkable story. The bill was introduced in April and May in the various chambers of Congress, and it passed on July 28th. So let's unpack that for the second. This Congress and in this political atmosphere, that bill went from introduction to enactment in less than 3 months, or I guess a little more than 3 months for the House bill. What it does was it addresses the organ transplant system by strengthening accountability, transparency, equity, and performance in organ donation and transplantation. This was long overdue. People in the community know that the transplant system has been very flawed over the last 20 years. And this bill will help try and provide some transparency and sunshine into how the transplant system works. And, what happened was that there was just tremendous bipartisanship on this, and there was the unquestioned merit of the issue. Everyone knew something had to change. So this led to uncommonly swift enactment of this legislation, and it's something for the community to be celebrating. So with regard to wrapping things up, Congress is back to work, but the divided government should tamp down any expectations for a ton of work happening. Fiscal year 2024 funding is still yet to be resolved, and if I were to take a guess right now, I would say a government shutdown will occur on October 1st. I think there are better than even odds of that happening. But progress on other issues is more reasonable to expect once that happens, of course. And of course, for organized medicine, everything we're trying to do right now is to make sure physician reimbursement is resolved equitably for 2024, and also that the formula that causes these problems every year is addressed as well. And, there was a narrow pathway for more parochial issues like living organ donation before, but we think that's broader now. And the things that happen in every Congress, will there be a Medicare vehicle? Will there be a big bill at the end of the year? They all still exist. So we'll just have to see what happens with that. There's my contact information. Follow me and RPA on Twitter. And I think that's it. Thank you.
Rob, thank you so very much for joining us again. And I know you're a veteran of many of our events. We never grow tired of hearing your insights, and you can count on us to be a solid ally in making certain that we're partnering with RPA to make certain that those who take care of us are compensated fairly for the work they do and for the level of expertise they have in their years of education. Thank you so very much. Our next speaker is Elizabeth Lee, and she's the Principal and Healthcare Group Chair for Venn Strategies. Over the years, many of you out there have gotten to know Venn Strategies for their aggressive advocacy on behalf of patients and innovation. And Elizabeth represents Venn Strategies on the Partnership for Part D Drug Access. And Elizabeth is going to talk about the 6 protected classes of drugs, including transplant drugs, and why organizations like ours and hers are very focused on any efforts that would take some of these drugs that are protected, like transplant drugs, and put them in a situation where they could be negotiated or where your access could actually be decreased. This is a very important issue for all those who aspire to have a transplant or who have a transplant. Elizabeth, go right ahead. We're happy to have you.
Paul, thank you so much. I am so honored to be here with AAKP to talk a little bit about Medicare's 6 protected classes. And before I go on, I just want to say how lucky you all are to be a part of AAKP. It is one of the best partners we have in terms of protecting Part D access. It is a both passionate and effective coalition, which is very rare for a patient group. So just want to say it's a special privilege to be here with you all today. So I am a principal at Venn Strategies. My name is Elizabeth Lee, and we have the privilege of supporting the Partnership for Part D access. So a little bit of background about Medicare Part D. In 1965, the Medicare program was created, and it covers 65 million adults today. But when it was created in 1965, Medicare did not include drug coverage at all. It actually wasn't added until 2003. But the Part D benefit was added in 2003 in order to provide optional drug benefits to beneficiaries. And today, in 2023, about 77% of the 65 million Medicare beneficiaries are enrolled in Medicare Part D. About half of those beneficiaries are enrolled through what's called a standalone drug coverage plan. The other half have their prescription drug coverage by Medicare Advantage plans. And as you all know, Medicare covers seniors over 65 and also folks with disabilities, including end-stage kidney disease. Those folks are less likely to be enrolled in Medicare Advantage plans, so most get their drug coverage through those standalone Part D plans. So from the very beginning of the Part D prescription drug benefit program, policymakers have recognized that certain Medicare beneficiaries simply have different relationships with their drugs. These are not drugs by choice, these are drugs for survival. We need timely, uninterrupted access to these medications. So this policy ensures that all or substantially all medications to treat these serious conditions are covered by Part D plans. Part D requires plans to cover these drugs in 6 classes: antidepressants, immunosuppressants, antioplastics, antipsychotics, anticonvulsants, and antiretrovirals. And Congress created this policy to protect Medicare beneficiaries with some of the most serious health conditions: mental health challenges, cancer, HIV, epilepsy, and those at risk of organ rejection. Given the complex nature of many of these diseases and the fact that many people are often suffering from multiple chronic conditions, it's critical that people have access to these treatments. Finding the right treatment for the right patient means better health. It means overall improved health outcomes, and it reduces the uncomfortable side effects that might otherwise lead to treatment abandonment and increased healthcare costs overall. So CMS, the Center for Medicare and Medicaid Services, in their own words, they said that limiting access to drugs increases costs to the Medicare program. And you can understand why. More likely to be hospitalized, more likely to show up at the emergency department, you have to go to the doctor more. That's costs to the Medicare program that could be saved if you're simply getting the right drug at the right time. In 2016, researchers estimated that less generous coverage would result in $475 million a year in Medicare spending and medical complications. So the Partnership for Part D Access is a patient-led coalition that is committed to protecting this policy. We are committed to maintaining a beneficiary access to the full range of medications under Medicare Part D, every drug in every class that I just talked about. And we represent and care about individuals who would be negatively impacted if Medicare were to change that protected classes policy. And I want to come back to patient-led. We are a coalition of over 100 groups, the majority of which are patients, and we protect them day in and day out. That's why we're here, and that's why we do our job. So I don't want to go further before talking about our reason. This is Glenda and Ike, and this is the reason. Glenda and Ike are one of the millions of reasons that we get out of bed every day. Glenda was a double transplant recipient in 1999, a kidney and a pancreas from the same deceased donor. She has 2 daughters and 2 grandsons, and she also takes care of her sister's kids. Family is her reason for living, and Glenda is our reason for fighting. So Glenda takes 2 medications every single day so that she doesn't reject the organs that were transplanted in her 24 years ago. But she needs to stay on those medications. And her doctor has told her, this is the regimen that works for you. And Medicare needs to ensure that those drugs are always covered. So Glenda has been one of our most passionate and advocates in the partnership. And every time she gets to talk to a policymaker or do a briefing, people connect the dots. They understand that Glenda would not be with us. She would not be with her family today if she wasn't able to access the medications that she needs to take every day. So understanding patient communities, a little bit more about the organ transplantation community. If we eliminated immunosuppressants from those 6 protected classes that I talked about earlier, they would place people who received any transplant at risk for severe medical complications. Immunosuppressive medications, as many of you know, are not interchangeable. Even if they have the same generic name, versions of a medication from different manufacturers affect people in different ways. Immunosuppressive medications are prescribed in combinations tailored to meet the unique needs of the individual recipient, and those needs and drug combinations can change over time. That is between you and your physician. We should not have an insurer telling you that you could not access the drug that you need that works best for your health. If prescription drugs are filled without regard to consistency from one month to the next, the recipient is subject to increased risk of rejection of their organ transplant, along with additional clinic visits, lab costs, and potentially going into the hospital. That is a huge disruption to a patient's life and a huge drain and more costs to our medical system. So what's going on right now? We have gotten a bit of pushback, as you might be able to imagine, from Part D plan sponsors. And they say that they don't want to cover all the drugs in the 6 protected classes because it's their job to control costs in the Part D program. So we took a look. We said, look, what are Part D plans doing right now to control costs? And guess what? They have the ability to do so through 2 things: utilization management and specialty tiering. So as I said before, all the plans have to cover all the drugs in the 6 protected classes. So that means it has to be on the drugs formulary. Once it's on the formulary, they can do step therapy, fail first. They can put it on specialty tiers, which means that they're able to manage the access to those medications and control the costs. The backstop, the protection for patients, is that those drugs will never drop off the formulary. So we found that plan sponsors employ utilization management tools at least 40% of the time, and nearly 2/3 of all covered medications in the 6 protected classes were placed on a non-preferred or specialty category. Part D plans have the tools to manage costs of the drugs in the 6 protected classes, and we cannot let them go to Congress and tell them to remove any of the classes that are currently in law. A recent study found that actually just 54% of drugs across the protected classes are on the formulary. So they've figured out a way to work with CMS to not even have to follow the letter of the law. They have the tools. We cannot let this policy be eroded further. So what's going on right now in Part D policy? So it's a busy time, actually. So IRA in this slide stands for the Inflation Reduction Act, and that was passed last year in 2022. And so that the intent of that law was to increase access to Medicare drugs and to make those more affordable, which is a laudable goal. And part of it is to redesign the Medicare Part D program to increase access to drugs, reduce cost sharing, all of which is a completely laudable goal. Our focus is to make sure that as CMS makes changes to the Medicare Part D program and redesigns it, that they not lose sight of the 6 protected classes and how important they are, and they continue to enforce that. So recently we sent a letter with the AAKP to CMS to say, as you implement any changes to the Part D program, we will be watching. We will make sure that you are still protecting access to the 6 protected classes, and we want to increase the transparency and have you actually report out on the kinds of enforcement mechanisms you were using. So we just sent that letter last week. We're looking to meet with them in the coming future. And in 2025, the Part D redesign will go into effect, and we will be watching even more closely and making sure that the patients that we protect have access to the medications that they need. At the same time, in Congress, there's increased focus on pharmacy benefit managers. Now, pharmacy benefit managers are the folks that are running these Part D plans. And this is great. We welcome this. There should be a focus on pharmacy benefit managers, as there should be in every part of the pharmaceutical supply chain. And so we'll be interested to see the interplay between what Congress is trying to do and how PBMs respond. And it just sort of adds another fun complication and nuance to the work that we're doing. So essentially, Part D policy and the 6 protected classes is always relevant to what's going on between Medicare administrative changes and potential congressional changes on the Hill. So the partnership goals, in light of the context that I just discussed, maintain full and complete access to the 6 protected classes, ensure that any changes to the Part D program do not erode access to the 6 protected classes, and stay vigilant against potential threats. So since the law has been in effect since 2003, there have been a couple different threats over the years. Maybe we should take away one of the classes, make it the 5 protected classes. Maybe we should give more flexibility to the plans. There's always a party at the margins trying to eat away at the 6 protected classes policy, and we have to stay vigilant against any potential threats. And the strength of the partnership and partners like AAKP have been able to beat back those threats, but they're always there. And that's why we have to stay right on top of it. So the next steps, we would love your help. Anyone watching this presentation, we would love your help in DC. So educate, advocate, protect. Those are the three things we're going to be focusing on for the rest of 2023 and all of 2024. So we've been holding a number of congressional briefings, and Paul was actually nice enough to join us for one. And these are really for staff. They're not for members of Congress. A congressional briefing, and many of you have participated, is for a new staffer, a junior staffer, somebody who's just getting to know health policy, the Medicare program. Those people need to know about the 6 protected classes policy. They just need to have a foundation in what the law is and what CMS is expected to do. And these staffers, they have a lot on their plate. They're learning a lot. We just need to be right there, right in front of them, making sure that they understand what this policy is. And then we can follow up with one-on-one meetings. But we love to bring people who are in their districts or their states, because those connections are so important for building championships and connections. And the other is op-eds and social media. So there's op-eds obviously available in every local market and state. There's also op-eds that can be in DC that can get a wider audience. And social media, as you all know, is a great way to get out the word about the 6 protected classes. So then advocate. We have to ensure that no matter what, Congress and CMS continue to protect the 6 protected classes benefit, even if other reforms are considered. And there will be. Pharmaceutical policy is always on the table in DC. There will always be changes on the table. We just have to make sure that those protections are there and we can maintain the current level of access. And we love, as I said, to connect patients to key members of Congress. Some members of Congress are swayed by different, they have different diseases and different patient communities. So we love to ask different patients to come in and meet with their members, throw in a tour of the Capitol on the way, and we'll make it fun for you. And the last is protect. And this is a word I know I've used a lot today, but we have to guarantee transparency from CMS on their efforts to enforce existing law. A lot goes on behind the scenes between CMS and the Part D plans. We don't always see the back and forth, and we don't know how that all works. But we'd love to increase the level of transparency to make sure that our efforts to protect the policy are working. And the last, I know I've said vigilant a couple of times too, but we have to do vigilant oversight of CMS and the Part D plans. And we're looking forward to working with our champions in Congress to make sure that they are doing that oversight as well. The partnership can only do so much. We're a private organization. We want those members of Congress who have expressed support for this policy to stay on top of the CMS who implements the law and the plans themselves to make sure that they're being transparent about their enforcement of the law. And that's my last slide. And it was really such an honor and a privilege to join you all today. Paul, thank you so much for having me. This was such a privilege to be here with you all. Thank you for everything that you do on behalf of patients every day. Thanks again for the opportunity.
Thank you very much, Elizabeth. It's always a pleasure being a partner with Venn Strategies and to be working with you on the protection of the 6 drugs that are in the protected drug class, especially transplant drugs. We'd now like to welcome Michael Penn, another good friend and an ally to AAKP. He serves as the head of public policy and government affairs at Boehringer Ingelheim. Michael will talk to us from a commercial side and also an industry perspective of what it means in terms of the 6 protected drugs. Michael, go right ahead.
Thank you, Paul and AAKP for having me. It's a pleasure to be here. And thank you for allowing me to share some information about the Inflation Reduction Act, or IRA for short. Specifically, I want to focus on its prescription drug provisions, and in the next few minutes, I'll provide a high-level overview of the key drug provisions, delve into those provisions that are patient-friendly, examine the challenges of the Medicare negotiation or price-setting program, stress the importance of patient engagement, and offer some guidance on how you, as patients, can participate in the Centers for Medicare and Medicaid patient listening sessions. The IRA is a significant piece of legislation aimed at addressing various cost challenges with the Medicare program, and within it lies provisions that directly impact prescription drug pricing and patient access. These key provisions are as follows. The Medicare Drug Negotiation Program allows Medicare for both Medicare Part D and Part B to directly negotiate with pharmaceutical companies to set drug prices for selected products. The first year of this program is already underway. In fact, it started on September 1st of this year as the selected drug list of 10 products was released. Additionally, the government will assess penalties for pharmaceutical manufacturers that increase drug prices beyond a certain benchmark. These penalties are intended to discourage price hikes that significantly outpace inflation prospectively. Within the IRA, there are several patient-friendly provisions that I want to cover as well. These provisions are designed to focus on patient affordability for Medicare beneficiaries. Some of these key aspects include capping out-of-pocket costs. The IRA established an annual out-of-pocket cap on expenses of $2,000 for Medicare Part D beneficiaries. This cap would limit the amount that patients must spend on prescription drugs before catastrophic coverage kicks in. This provides more financial protection and predictability of out-of-pocket costs. The law also provides an additional set of assistance for beneficiaries by allowing their enrollment in a program to spread patient out-of-pocket drug costs over the course of their benefit year, very similar to a payment plan. Other provisions call for a $35 copay on insulin and no cost sharing for Medicare-covered vaccines. And now, while the idea of Medicare negotiation for prescription drugs, or price setting as we call it, may seem like a straightforward solution to high drug prices, and proponents of these price setting policies believe that they could result in cost savings for both the government and Medicare patients. Now, this policy comes with a set of challenges that may have a sizable impact on patients and the healthcare system overall. This includes price controls or price setting may lead to reduced access to certain medications. It may stifle innovation by limiting the resources available for research and development. And as we know, R&D is a risky, lengthy, and costly process necessary to develop a new medicine, and it can require an average cost of several $billion and can take anywhere between 10 to 15 years to bring to market, with only 12% of those medicines entering clinical trials ever obtaining FDA approval. In addition to seeing fewer incentives for R&D and for innovative and novel therapies, ongoing research for existing therapies after they reach the marketplace will also be negatively impacted. Because these medicines can be selected so early, companies are also discouraged from doing R&D in the years following a medicine's initial FDA approval, reducing the potential for additional discoveries that enable a medicine to reach a more diverse and larger patient population. The law also allows for price setting process for pills and capsules to start as early as 7 years after they are first FDA approved, which is long before the end of their average 13 to 14 year effective patent life. As a result, the pill penalty, as we call it, may discourage companies from researching and developing small molecule medicines at all. We may see potential patient access disruptions to existing therapies and fewer incentives for innovation in certain therapeutic and disease areas like oncology, mental health, and other rare diseases. Insurance companies and PBMs can still change coverage of medicines, including those that are price set by the government, by moving them to more expensive, non-preferred, and specialty formulary tiers that have higher patient out-of-pocket costs. And some companies, insurance companies, could even stop covering some medicines altogether, since they are only required to cover the price set medicine and maybe one other medicine in most therapeutic classes. Finding a balance between negotiation or price setting and ensuring access to innovative treatments is a complex task. The pharmaceutical industry is seeking to strike that balance by advocating for implementing policies that allow those selected therapies to have unrestricted coverage and patient access in Parts D and B. Specifically, these policies are designed to not disrupt good coverage and access already achieved for those most innovative therapies and not to inhibit novel therapies from being available to patients so that the right medicine will reach the right patient at the right time. Now let's talk about why your active involvement is vital. As patients and Medicare beneficiaries, your voices matter. You are the ones directly affected by these policies, and your input can shape the outcome of these policies. Advocating for your needs and concerns is crucial to creating a healthcare system that truly works for everyone. So CMS will be scheduling patient listening sessions to be held between October 30th and November 15th of this year. There will be one listening session for each of the selected drugs, and a full schedule of these listening sessions can be found on cms.gov. CMS will not respond to comments during these listening sessions, and then interested parties can register for a chance to give a public statement during one of these sessions starting September 1st. Registration for that opportunity will close on October 2nd. We would encourage you to participate in as many sessions as you are able to. The Jardiance specific session will be held on November 8th for your reference. Things to keep in mind as we think about these listening sessions: CMS will randomly select approximately 20 speakers for each of these sessions. Each public statement will be limited to no more than 3 minutes per person. And then additionally, we want to ensure that you have an understanding of what you can consider to discuss and what you can actually do to take control of your access to these therapies, as well as navigate these patient listening sessions. We want you to participate in the CMS patient listening sessions and provide direct feedback to those making decisions. We want you to share your experiences. That means personal stories, anecdotes about your experience on the selected medicine. And those stories can have a significant impact on policymakers. That's also important for you to stress that you want to maintain continued access to the medicine and the importance of choice of being on that therapy. The benefits of that medicine to certain groups or patient population, those are anecdotal examples that can be shared as well as sharing the unmet needs of the patient and even the caregiver experience, including the burden related for caring for someone with that particular disease. We also encourage you to seek support, join or support organizations that represent your interests. We want you to stay informed, educate yourselves about the issues, the Inflation Reduction Act, and its provisions. And ultimately, we want you to communicate with your representatives. Reach out to your elected officials and make your concerns known. In summary, some of the Inflation Reduction Act's prescription drug provisions are a critical step in addressing the affordability and accessibility of medications. While patient-friendly provisions offer hope for improved access, we must remain mindful of the challenges that come with Medicare negotiation. Your involvement in this process is essential. By actively participating in CMS patient listening sessions and advocating for your needs more broadly, you can help shape policies that have a direct impact on your healthcare. Policies that improve the healthcare system so that it is not only efficient and cost-effective, but also so that beneficiaries and patients have undisrupted access to the most innovative and effective therapies. And that is essential for ensuring that patients receive the care and access that they need. Thank you for your attention, and I encourage each of one of you to make your voices heard in this important conversation. And please register for your respective listening sessions. Thank you very much.
Thank you very much, Michael, and thanks for being part of Under the Dome. Our next two guests are from CorMedix. And CorMedix has been working on an innovation that addresses and targets a very, very important issue for kidney patients, especially kidney patients that are dependent upon hemodialysis. And this is a new innovation that fights bloodstream infections for those who are dependent upon a catheter. And so, without further ado, we have Erin Mistry, who's the Chief Commercial Officer for CorMedix, and she is also joined by Elizabeth Mason Hurlburt, who's the Executive Vice President for Clinical and Medical Affairs. Now, they're going to talk about an innovation that CorMedix has called DefenCath. This particular new innovation is of tremendous interest to AAKP, given the huge number of bloodstream infections that occur for hemodialysis patients, and sadly, the high degree of mortality that's accompanied with this. Erin and Elizabeth, go right ahead. We really do appreciate you being part of Under the Dome this year.
Thank you, Paul, and thank you, AAKP, for having myself and one of my colleagues, Liz Hurlburt, on for this presentation. We're here to talk to you today on a number of different fronts, but the main one is preventing infections and saving lives. And we all know that dialysis patients are susceptible to infections for a variety of reasons, and they're susceptible to health disparities in care. And so we want to discuss some broad pieces, but also some of the specificities around this patient population that CorMedix is actually here to work with. Just a quick overview for today. We're like I mentioned, we're going to give an overview of an urgent call and the benefits of reducing healthcare acquired infections. We're going to go through what healthcare acquired infections actually are. A subset of those is called CRBSIs, which are catheter-related bloodstream infections. So dialysis patients that have catheters and receive dialysis are even more susceptible to them. And then we have a call to action. Why we're here today to talk to AAKP about what can be done to further policy efforts to reduce these infections and keep patients safe. And then we have a couple extra slides in appendix if we need them. For the first piece here, we want to talk just at the broad global level about reducing the rising infection trend. We're trying to make healthcare safer for all. And when you have a big problem like infections, we've all been through the COVID era, and we'll continue to utilize policies that were put into place at the time to combat those. But we're also here to talk about the rising healthcare acquired infection trend that's happening. And these are threats to patient safety. They actually impact long-term complications while generating a significant cost in the healthcare system. So they're not only obviously reducing quality of life for patients, but there's a heavy mortality and morbidity risk associated with these as well, which leads to part of the challenge that we have in our healthcare system is the costs. Very, very few number of patients cost the healthcare system a lot of money. They also result in antibiotic use. And so the more infections that we get, the more antibiotics we need to use, and the more we are prone to resisting those antibiotics. So the whole goal of the antibiotic stewardship programs and antibiotic resistance programs is to reduce the number of antibiotics that are used. And we can do that from a prevention standpoint. But the system doesn't reward for prevention. And I think that's the biggest thing is how can we go earlier stream for these infections and start to prevent them before the use of antibiotics needs to take place. From a population standpoint, healthcare acquired infections are vary differently, but the Black patients have 2 times as many hospital onset MRSA infections than white patients. There's higher rates of bloodstream infections amongst Black and Hispanic patients than white patients. And these obviously differences are due to a lot of disparities, but healthcare access, quality of care that's received, ability to afford from a nutrition standpoint. There's a lot of things at play here, and we can reduce those quite a bit if we put the efforts together. So we're looking for broad and equitable access. And eventually we get down to the mechanics of the system and the reimbursement that we can provide to these patients, but we have to move CMS in the right direction from a prevention standpoint. So the benefits of reducing the healthcare acquired infections, as you probably imagine, are far-reaching. So we're avoiding preventable deaths and long-term complications. We're reducing those racial and socioeconomic health disparities. The economic burden on the healthcare system is reduced. And then we're preserving antibiotics for when they actually are needed versus using them quite often for routine infection prevention or routine infection treatment. And so we want to make these, there's tons of research and development going into products that can help with this. And we need to make sure that these products are accessible to both clinicians themselves and to patients. So one of my colleagues, Elizabeth Hurlburt, is going to take it from here.
Thanks, Erin. So I'm going to talk a little bit about healthcare-acquired infections, or HAIs, which are infections people get while receiving healthcare in the hospital, in dialysis centers, in infusion centers, or other settings of care. So first, I think it's critical to emphasize that most hospitals and clinicians have rigorous infection prevention standards, from hand hygiene to wearing the proper PPE to enhanced cleaning and disinfection, education and training, and of course, antimicrobial stewardship. So their focus is on ensuring that right antibiotic gets used in the right patient at the right time, right? And the goal is to prevent drug-resistant infections. So addressing HAIs requires implementing and adhering to all of these protocols, and also recognizing that sometimes, even with the most diligent efforts, these bugs or bacteria remain, and these infections can be insidious. So HAIs are a preventable public health crisis, right? So in most cases, HAIs are preventable, but they require a multifaceted approach, right? Sometimes some of the most needed healthcare interventions, like surgery or the placement of a central venous catheter, can lead to these life-threatening infections, and that puts clinicians in a very challenging position. They need to intervene to save a life, and at the same time, this looming threat of a very serious infection hangs over them. So we can mitigate the risk of this with broad, equitable access to scientific breakthroughs and innovation that actually prevent infection instead of spending all of our energy treating them. In the past 5 years, we have unfortunately seen a spike in healthcare acquired infections due to a number of reasons. We're all well aware of the COVID-19 pandemic, which had an unprecedented impact on our healthcare system, but it is not the only factor in that rise. We have seen increased antimicrobial resistance, more immunocompromised patients, invasive procedures, and really limited resources and understaffing that has greatly contributed to this problem as well. And with that, there was a 37% rise in staph infections. So staph, which is caused by the bacterium Staphylococcus aureus, can cause a wide range of infections. Some are simple. They're easy to treat skin infections, but others, and often the ones you see in CRBSIs, are serious life-threatening ones. And those can lead to bacterial pneumonia, bloodstream infections, and sepsis. Staph, in general, can be very difficult to treat due to antimicrobial resistance. And staph can cause biofilm, which are these sticky layers of bacteria that can protect themselves against antibiotics, making them very difficult to treat. And it also allows for this persistent colonization or continued replication of the bacteria, which can allow for patients to get recurrent infections and make them more difficult to treat. In the US, HAIs are really threatening patient safety, and they're even widening that gap that we already see in health disparities, and they're generating a significant avoidable cost that, quite frankly, is not sustainable to the system. So the impact that HAIs have on patient safety and the system is almost immeasurable, but I think we've done a good job capturing some of these numbers here. CLABSIs are incredibly expensive to treat, right? Placing a burden on the system that is significant. Patients with CLABSIs often have extended hospital stays. They require multiple interventions and medications. There are significant rates of mortality and increased comorbidities, and the institutions themselves are hit with higher penalties and increased regulatory fees for these high rates of infections that happen. Something I think that's important to note here that really probably resonates with a number of minority hemodialysis patients is that Black patients are more than 2 times more likely to have a hospital onset staph infections. And so many Black patients are already facing major factors that contribute to substandard outcomes, right? In general, patients that come from racial and ethnic minority groups are more likely to experience poverty, have limited access to healthy foods, transportation, housing insecurity, and limited educational opportunities. When you combine that with the implicit biases and barriers to healthcare access, as well as historical traumas, we have a serious challenge on our hands. We need systemic change when it comes to preventing infections, and only by improving access to quality healthcare and innovation can we start to dismantle some of the structures that create and perpetuate these inequities. HAI treatments can lead to antibiotic-resistant superbugs. So while they sound like a buzzword, these superbugs are a serious issue, right? And the overuse or misuse of antibiotics or antivirals can lead to an environment in which only the most resistant organisms can survive. So when a patient has a drug-resistant infection, providers are left scrambling to treat them. So this can lead to extended hospital stays where people are missing more time from work. There's a significant impact on quality of life. You're away from your family. There could be time in isolation rooms and multiple interventions and very high-cost treatments that can have significant side effects. Antimicrobial resistance is a serious public health concern that disproportionately affects certain groups of patients and can result in high morbidity and mortality. CRBSIs. So let's talk about catheter-related bloodstream infections. So these are a subset of the more common term CLABSIs or central line associated bloodstream infections. And something to keep in mind here is that all CRBSIs are CLABSIs, but not all CLABSIs are CRBSIs. CRBSIs are a common healthcare-acquired infection that really do threaten patient safety, widen disparities, and add significant costs to the health system. CRBSIs, if you want to think about them, are infections that happen within the catheter. So your catheter is made up of a number of different parts, but the longest and most significant parts are the lumens themselves. And so different catheters can have a different number of lumens. In hemodialysis, patients have 2, the arterial and the venous lumens. And in those lumens where medications get flushed through and they're accessed at each and every dialysis session and cleaned, those lumens in between have a time that they sit there without medication in them where it leaves them ripe for infection to start developing because a bug may have gotten in there, biofilm may have started to develop once that catheter was placed. So that's where you see the genesis of many of these CRBSIs. Catheters, particularly in certain hemodialysis patients, are really a lifeline, right? While the Fistula First initiative has been aimed at increasing the use of fistulas, and we know that's ideal access for many hemodialysis patients, CVCs are often what hemodialysis patients start on, and many patients, whether it's by choice or because of vascular structure or age, need to stay on CVCs, and their life depends on keeping that line safe. So we see that over 5 million central venous catheters are inserted every year, right? And those are to deliver life-saving treatments like hemodialysis or chemotherapy in an oncology patient. With that, there's over 250,000 CRBSIs that occur in patients each year with a CVC. And CRBSIs lead to more hospital admissions, more hospital readmissions, longer stays in the hospital, and serious long-term complications, including multiple recurrent infections and cardiovascular events. I think one of the most sobering factors is that 1 of 4 patients can actually die from a CRBSI, because these infections are so serious, they travel directly to a patient's heart. So through the bloodstream and right to the heart with very serious, sometimes fatal consequences. So CRBSIs are a public health issue, right? So they are most often seen in these 3 groups, which really parallel with many of the hemodialysis patients that we work with. So persons of color. So there are higher rates of CVC use in Black and Hispanic populations, which are therefore associated with higher CRBSIs. The elderly. So we have an aging population, and the longer you're living, the longer you're going to be on that catheter. And unfortunately, with age, you have multiple comorbidities. There are increased medications that could potentially interact, right? Decreased organ function, potentially less awareness of the signs and symptoms of infection. And so you do see a rather high rate of 20% of geriatric patients with CRBSI will die from that infection. And lastly, like we talked about before, the socioeconomic status of patients really does come into play here. So the financial stability and education of a patient can impact the risk of developing a CRBSI, right? So patients that are living below the poverty level, who may not be able to get to their dialysis treatment consistently, who may struggle with transportation or being able to keep the bandage safe on your CVC, those patients unfortunately become more vulnerable to acquiring a CRBSI. So inequities in the incidence and outcomes of HAIs among minority populations potentially stem from these social determinants of health and disparities in HAI prevention efforts. There are significant impacts that CRBSI has not only on medical care, but also the impact that it can have on additional health complications. So CRBSIs, let's just take the hemodialysis community. If you are a CVC patient, an HD CVC patient, eagerly on the transplant list, this is such a significant time in your life while you're waiting for this life-changing transplant. And if an infection occurs, it certainly will pause, if not potentially cancel out the transplant, which is just emotionally devastating. And the delay in care keeps you on the CVC longer, not to mention the infection itself and having to have that treated. But identifying another donor could take months, if not years. There are also significant 1-year incremental rates of serious health conditions like stroke and cardiac conditions like dysrhythmia and congestive heart failure, endocarditis, osteomyelitis, some really serious comorbidities that can happen and really start as a domino effect of the initial CRBSI. CRBSIs have a significant economic burden on the system as well. Nearly 4 times higher average length of stay. So when you think about somebody going into the hospital just a few days and how disruptive that is, having to take time away from the family, losing income potentially, if you are quadrupling that number and thinking about not only what it's doing to the patient, but also what it's doing to the system in terms of nursing care, medications, bed space, these are significantly impacting stakeholders across the landscape, patients, clinicians, and hospitals. We are seeing here that CRBSIs emerge rapidly, right? So when a patient potentially crashes into dialysis, or even if they're not crashing and they need to initiate dialysis, and they're starting with the CVC while maybe the fistula is maturing in that time, infections are starting very quickly. And we're talking both in non-tunneled catheters and permanent tunneled catheters, which are what are used for HD patients. 40% of patients who develop an infection do so within 30 days of having that CVC placed, right? So it's being placed in the right area in the hospital under the most sterile of conditions and being taken care of, but biofilm starts developing very rapidly. And you've got a lot of folks going in and out of that catheter in the beginning when patients are starting to stabilize on dialysis. They're learning how to take care of that line. They have to remember not to shower, and there's just a number of opportunities for bacteria to be presented, right? And those bacteria emerge very rapidly. And when that happens, right, we see 40% of patients in 30 days, more than 50% within 90 days. You start looking at the morbidity rate at the 6-month mark for patients with CRBSIs is 37%, right? That is more than a third of patients that are dying because of something that is preventable. So prevention efforts can realize not only significant economic savings, but really improve health outcomes and quality of life. CVCs are vital to healthcare. Doctors need them, patients need them, but they do present us with a challenge, right? Because to follow the dictum, first, do no harm. Hospital leaders need to remain vigilant in their prioritization of patient safety, but also need to continuously be looking for new drugs, new technologies, and innovation to be able to realize that promise.
Perfect. Thanks, Liz. So I think you guys heard from Liz. You saw the severity that she talked about with these infections and the mortality associated with them and all of the things that can actually be prevented. And I just have a couple slides here on some of those initiatives that are taking place at a higher level. And this is where we are speaking to AAKP, and the interest that AAKP has on these issues should be pretty prevalent, right? We want to hear through AAKP some of the challenges that patients have had around getting access to medicines, the impact that infections have had on the lives of patients. And we want to, generate that interest at the congressional level so that it continues to be front and center for policymakers. One of the biggest things in the system is that it's so fragmented. I think we all know that, we've heard that, but no products come to market unless there's clinical and financial alignment in the system. No matter how good a product may be, there must be money in the system for it to get used, right? Whether that goes back to providers or to Medicare, fee-for-service, whatever mechanism it flows through, there has to be both clinical and financial have to be there. And the FDA has done certain things, right? There's a lot of movement in this area. They've provided designations like a qualified infectious disease product to reward for reimbursement for products that have reached a certain clinical threshold and have been deemed substantially beneficial. So I think when we work together with these stakeholders and continue to put it front and center, we can get there and make sure that these innovations continue to come to market. One of those initiatives is with the CDC, right? There's a couple others that we'll talk about in a few slides, but just from a high level, the CDC has recognized that health professionals should prioritize prevention and implement those best practices to prevent bloodstream infections. And so they have realized that this is very important and should be part of their priorities. And we'll go through the CDC priorities in a little bit, but it's our responsibility, just like you've seen in other disease areas where oncology or cancer patients or rare disease patients, there's a priority there, and the infection space just has not been able to generate that level of interest. And that's really the big difference here, is to pull these things through, right? With the CDC and HHS and CMS, pull them through, but then also get them utilized. And that's where CMS comes in. And so we're really trying to move the system broadly in this area. So from a CMS perspective, reducing healthcare required infections is a priority for them as well, right? So it actually hits on a number of their priorities, and 3 specifically. They've got 5 priorities over the next 10 years from a strategic perspective, and this touches on 3 of them. Those 3 are advancing health equity, driving innovation, and protecting programs. And that's responsible stewardship of public funds. So fewer infections will result in lower use of healthcare resources and avoiding necessary spend. So here we just talk about, look, we can't sit back and wait for another public health crisis when we have the opportunity right now to be more proactive versus reactive and prevent infections with mitigation innovations. And so we have an ability to use evidence-based medicine and move the needle forward. We just need the system to work together with industry and with other parties cohesively to be able to do that. And that the groundwork is laid, but there's still collaboration across the system to ensure that proven innovations can significantly reduce infection risks that reach patients quickly, broadly, equitably, and sustainably. And that's our mission. And so this just looks at the history, right, of how policymakers can actually impact innovation. And usually it spans over a number of years, but that's what it takes to move big bodies in government. And so we need to continue to move it forward. We're at a cusp right now where there's a lot of pieces that can come together and fall over the next couple years. And we're going to continue to hit those mission critical activities to make that happen. So you can see 2006 Medicare Part D was announced. You've got from a protection standpoint from a planet, we've got energy alternatives for the 21st century. We've got making care accessible, narrowing the equity gap with the telehealth initiative, and then there's special FDA pathways that they've realized that can provide reimbursement for innovations. And so kind of the last one is where we are now, the last 2 actually, but we're moving the needle and we just need AAKP's help and power to be able to do that.
Thanks, Erin. So I'm going to touch a little bit on the Locket 100 trial and some of the initiatives CorMedix is working on to look beyond Locket 100 and really how we can take what we learned in Locket 100 and apply it on a much broader scale. So I have to say, I'm so proud to work for a company that has really, put a stake in the sand to say, this is time to usher in a new era of patient safety. So CorMedix is a biopharma company based in New Jersey, and we are made of a small but nimble and fierce group that is really deeply committed to increasing patient safety and health outcomes through prevention and treatment of life-threatening conditions and diseases. So I'm going to talk about our study in a minute. I also want to talk about some of the things we have taken on post-study. We are thrilled to announce that we have a partnership with the Boston Medical Center, who is also incredibly dedicated to closing the gaps in health disparities. And so we are working with them very closely to take a retrospective look at CRBSIs and also how we can best partner within urban communities to get technologies like ours out to the community. We are working with the Antimicrobial Working Group to improve the regulatory investment and the commercial environment for life-saving antimicrobials. We've certainly seen how a number of products have come to market, and we really want to make sure that we are part of the solution for getting them out there and getting them into the hands of the patients who need them. And we've recently partnered up with Leapfrog as well. And Leapfrog is nationally known to be evaluating individual hospitals on safety and quality and efficiency. So it really is a special window for patients in the communities to be able to look at their local institutions to see where they are most safe and where there's been an investment on hospital quality. So let me talk a little bit about our landmark study, Locket 100. So Locket 100 to date has been the largest and most rigorous study done in CRBSI here in the United States. catheter lock solutions are not something that folks are often talking about. And quite honestly, I don't know that many dialysis patients even know what their catheter is being locked with, right? So when we started the study, we ran the study with our product, which we'll call DefenCath or Tauroladine heparin, against heparin, because heparin has been used as the standard of care to keep catheters patent for many, many years. And we know that it's done a great job reducing clots and keeping the line flowing for dialysis. So it was a randomized, double-blind, active control with heparin, parallel arm, multi-center study. So we ran this study in 150 hemodialysis units. So those units were Fresenius units, DaVita units, independent units, as well as a handful of VA hospitals through mainland US and through Puerto Rico. And what we were looking at was the time to CRBSI, right? And sometimes people go, why would you pick that as an endpoint? And it really is with that basic assumption that if a patient has a CVC, a CRBSI is going to occur. The question is when, and what can we do to keep that line as safe as we can for as long as possible to give the patient the best chance to let the fistula mature and transition over or get to transplant if needed. So primary endpoint, again, time to first CRBSI, and the secondary endpoints of catheter removal and loss of catheter patency. This study, while it was ran by CorMedix, did have an independent DSMB, or a Data Safety and Monitoring Board. And that you'll see as we go through the results. The DSMB actually recommended an early completion of our trial based on the efficacy and the pre-specified level of significance we had, as well as a very, very good safety profile at the halfway mark. Tauroladine heparin, right? So tauroladine, we can talk a little bit about, is the active ingredient in DefenCath. And tauroladine is a derivative of the amino acid taurine, and it is a broad spectrum, non-specific antimicrobial, which means it works on bacteria and it works on fungi. And with that, tauroladine heparin reduced CRBSI occurrence in these hemodialysis patients by 71%. So you can see here in the heparin arm, we saw 32 patients, unfortunately a handful of whom did in fact have a fatal outcome from CRBSI in the heparin arm, compared to the 9 tauroladine heparin patients who had a breakthrough infection. So we are very proud in the statistical world of what they call a p-value of 0.0006. So incredibly significant statistically, but really from an application standpoint, so significant from a clinical perspective, right? There has not been something to date that has gone through such a rigorous study that's shown a 71% reduction in infection.
Great, thanks, Liz. So for the next couple slides, we're just going to hit high level so that the members of AAKP understand all of the initiatives that are going on at various government agencies to drive home some of these points. And I think this is where the impact of AAKP really comes into play. Just very quickly, we touched on CMS earlier. This is a little bit of a deeper dive to the strategic pillars and quality strategies. So there's basically 2 pieces. One is the strategic plan, which I reviewed a couple slides ago, around CMS serving the public as a trusted partner and steward. So they're dedicated to advancing health equity, expanding coverage, and improving health outcomes. The second big piece from CMS is a national quality strategy, right? So this is a cross-cutting initiatives that aims to shape a resilient, high-value healthcare system to promote quality outcomes, safety, equity, and accessibility for all individuals, especially for those in underserved and under-resourced communities. And when we talk about infections, quality of care, this is one of the main pillars that we want to pay attention to. From a VA perspective, you can see their strategic plan and their strategic goals. Goal number 1 is to communicate with customers and partners to assess and maximize performance and build long-term relationships. Goal number 2 is that the VA delivers timely, accessible, high-quality benefits, care, and services to veterans, which this fits right into that. Strategic goal number 3. The VA builds and maintains trust with stakeholders through proven stewardship, transparency, and accountability. And then strategic pillar number 4 is that the VA ensures governance systems, data management. So when you put a product or you're looking to resolve a health crisis, you can't change what you don't measure, right? So we need the ability to capture the data and then continue to capture it year over year to monitor improvements. And the VA does that very well. They're a closed system and have the ability to get data like very few other systems do. From an innovation perspective, the VA is focused on the Center for Care and Payment Innovation. So this is where paying for things that actually make sense and actually benefit the economy and the overall healthcare system from an offset perspective, in addition to obviously patient lives. But they're very dialed into that and have a whole center dedicated just to do that from a value-based innovation perspective. And then the other one is the VA Office of Healthcare Innovation and Learning, right? And so these are areas that we would expect the members of AAKP to target and to call and to be involved with, especially if you are a veteran or know veterans that are affected by some of the things that we've talked about today. The next couple are just on CDC. I'm just going to touch on them very quickly, but the CDC also has a strategic plan. So we talked about the CMS strategic plan. We talked about the VA strategic plan. Now we talk about the CDC strategic plan, and this is covering 5 core capabilities of the agency. It's reflecting their commitment to equity and diversity, and then lifting up where they've invested through the COVID-19 pandemic. So they want a diverse public health workforce. They, just like the VA, want world-class data and analytics, state-of-the-art laboratories, rapid response to outbreaks at their source. And so we want, when we were talking about the infections today, that fits right into that category. And then they want strong global capacity and domestic preparedness. So if we are in another global health crisis like we were with COVID, such as AMR, that we would be able to combat that quicker and be more responsive. Specifically around the infection prevention and things that are going on for antimicrobial resistance, the CDC has a whole initiative around that. They lead the U.S. public health response in combating antimicrobial resistance. We talked about it earlier. Liz mentioned that we were part of the antimicrobials working group. These are all areas that AAKP can begin involved in and members can get involved in to help push infection prevention and making sure that your voice is heard. In addition to AMR, the CDC has core commitment to health equity. And so they've got 4 pieces that are part of that core: cultivating comprehensive health equity science, optimizing interventions, reinforcing and expanding partnerships, and enhancing capacity and workforce diversity. So again, another initiative within CDC that we feel is fairly powerful when we talk about health equity. And then finally, the last slide here is on kind of the HHS, Health and Human Services branch of the government, strategic goals and cross-cutting principles. They've got a strategic plan for starting in fiscal year of 22 all the way through 2026. Across the board, there's a number of initiatives here, and these flow, all these agencies. I think what we're trying to say here is all these agencies have goals and initiatives that can come together and fight this. And they're all very similar, different but similar. And the voice of AAKP can be very impactful as we get in front of Congress and political support to drive these campaigns and drive these initiatives. We appreciate you guys listening. I know there's a lot of information, but I think you can see how it ties together through one single product and its benefit to a broader patient population and how that impact can move policy and move payment structures. Our goal is to not stop here. We want this to be available to the sickest of the sick dialysis patients who are costing, from a cost perspective, the healthcare system a significant amount of money, and we can do something about it. At the end of the day, we can do something about this, and we are looking for partnering with you and supporting AAKP's efforts in a cross-functional way. I think on behalf of Liz and myself and CorMedix, we wanted to thank AAKP for the opportunity to share this information. We know it's a lot of information, but appreciate the support and look forward to continuing to work together to advance these initiatives. Thank you very much.
Thank you very much, Erin and Elizabeth. You can count on AAKP to muster the forces around the country to make certain that the patient interest and the patient need for a solution for bloodstream infections is said loudly and clearly and regularly to those who are weighing the decisions here in Washington, D.C. that will ultimately determine patient access and doctor availability of your product. Our next guest is Pontus Nobréus, and he's from Redsense Medical. Redsense Medical has developed an exciting innovation to control and to alert people to the issue of bleed out, especially hemodialysis patients. This is a very serious issue. If you get venous needle dislodgement, you could lose your life. It's a high-risk situation. We know it quite well. We've worked very closely with Home Dialyzers United on this issue. And so, without further ado, Pontus, go right ahead.
Thank you so much, Paul, for the nice introduction. And I really do appreciate to be part of this year's National Patient Meeting and make a presentation. Global kidney diseases is a big problem. And in the US, it's estimated that around 37 million people are affected by chronic kidney disease. If you have moved into the chronic kidney disease, you unfortunately have come to a phase of the disease where the kidneys will stop working. If you as a patient reach that phase, you have basically two options. One is to get a kidney transplant or to have dialysis. Dialysis is by the far most common treatment as of today. If you perform dialysis, it is mostly performed in a clinic or a center today. However, there is a growing demand for home hemodialysis, and that modality is gaining much more popularity nowadays. And that is thanks to all the good benefits that comes with it. It is actually clinically proven that you have a better clinical outcome for the patient, as well as many advantages when it comes to flexibility for the patient, and thereby having a better quality of life for the patient. In the US, there are around 12,000 patients that have chosen the home hemodialysis modality, and that number is growing all the time. And it's also promoted by federal initiatives as well as by the large dialysis providers. Every year, it's estimated that 75 million hemodialysis takes place in the US, both in the clinic and at home. And that is a very standardized treatment in one way, and in most cases it goes very well. But there are still some risks involved with hemodialysis. And one major risk is the risk that the venous needle is dislodged. That means that you have a blood leakage, and that can quickly turn into a large impact for the patient. You have to remember, when you do a hemodialysis, you circulate the blood through an artificial kidney, which is the hemodialysis machine. And you do that for several hours at a high flow rate, up to 0.5 liters per minute. And given that a person has about 5 liters of blood, it can quickly go bad should you have a venous needle that is dislodged. By the way, venous dislodgement is what we refer to VND. You have to also think about the bleed out time. It only takes 3 to 5 minutes to bleed out. So if you have a VND, you have to take action very quickly. In the US, unfortunately, 1,900 patients are affected every week by a venous needle dislodgement, and 200 persons actually die in the US from a venous needle dislodgement. So this is a serious issue and a big problem. VND is very unpredictable and can happen anywhere, anytime when you do the dialysis. Therefore, it's important to take advantage of modern technology to detect blood leakage to minimize the impact should a VND happen. Of course, I envision to have a monitoring device as a standard of care for all hemodialysis treatments. But you also have to look at what patients that actually are in risk. And there are studies that show that about 20% of the patients in a clinic are at risk. And the question is, which are those patients? Well, it could be a patient that actually are in the corner of the clinic. Could be a patient that is dialyzing in an individual room, or even during the night, that is called nocturnal. Could also be a patient that cover its arm with a blanket, or if you have a patient that does a lot of movement and maybe a little bit distressed. If you look outside the clinic, and now we're talking about the home dialysis, you can do that in different ways. You can, of course, do that hemodialysis at home when you have a caregiver, a partner close by. But you could also do it solo. You could also do it nocturnal in the night. And of course, in those situations, you don't have any professional caregiver close by. So by definition, you are at a much higher risk, I would say 100%. One way to mitigate the risk with VND is to use an FDA-cleared alarm system to detect blood leakage. This will add an extra layer of security and will bring peace of mind both to the patient and the caregivers. From the very start of Redsense Medical, which I obviously represent, we have been focusing on the patient in mind, and especially to solve the issue with VND and to minimize the impact should you have a VND. We have developed an easy-to-use alarm system. It's based on fiber optic solution, and it's a very easy-to-use alarm unit that you place close to the hemodialysis machine and the patient. It's just one button, should be easy to operate for the patient and the nurse. From that alarm unit, we connect a fiber optic cable. And that cable goes to the arm of the patient. And in the end, we connect a sensor patch. It's a non-invasive patch that will cover the venous needle. Should there be any blood leakage or the venous needle pops out, the blood will automatically be absorbed into the sensor patch. And with our unique fiber optic light going through this cable, we will quickly detect that there is blood leaking. And a noise will come out of the alarm unit, and it will start flashing to get the attention of either the patient, if you do it yourself, or your partner, or if you're in a clinic, the nurse. Should also mention that this sensor patch is also available in a version for a catheter if you're using that. And it's a one-time item, so you use one patch per treatment. The nice thing is that this is a standalone system, so it can fit with any hemodialysis machine in the market. And of course, our Redsense alarm unit is FDA cleared and used by all the major dialysis service providers in the US. Should you, as a patient, have an interest in such a solution to give you extra peace of mind and extra safety, I advise you to talk to your nurse or to the dialysis service provider. There is an increasing interest and drive for home treatment in the US. And to support that, it's very important to understand and address any concern that the patient may have when going into home hemodialysis. What are the risks, and what happens if there is a venous needle dislodgement? How can I as a patient feel safe and mitigate any risk for such an adverse event? Of course, these are very valid questions, and one answer is, of course, to use available technologies such as monitoring of blood leakage. And that will take away any fear that you as a patient may have doing home hemodialysis, and also give your partners and caregivers peace of mind. Therefore, we very much appreciate the efforts taken by the Congress with the Home Dialysis Risk Prevention Act. This act, H.R. 3118, is a bipartisan legislation to improve safety for those patients undergoing home hemodialysis by ensuring that end-stage renal disease coverage for devices that actually monitor the venous needle and gives an alarm should you have a dislodgement. This is a very important legislation that we support fully, and an enactment of the legislation is an important step to prevent any unnecessary fatalities and injuries from venous needle dislodgement. Since you never know when a VND will happen, a monitoring system can be compared to using a safety belt when you are in your car. When you jump in, you hopefully always buckle up, and you hope that it will never come into play, but you do it because you will want to feel safe. It's actually the same thing with a Redsense alarm. It's always there to give you peace of mind, and you hope that you will never hear it. Okay, with that said, I want to thank you for having the opportunity to participate in this important event, and I want to thank you all for tuning in and listening and your attention.
Thank you very much, Pontus, and I'd like to thank all of our guests who participated under this particular session of Under the Dome. Look, folks, getting innovation into the marketplace is not easy. A lot of people talk about innovation, but what they don't want to talk about is the tougher work, which is the payment side of it. When the federal government encourages innovation and companies stand in the arena and invest millions and millions of dollars and involve patients in clinical trials, and we work together diligently to bring new innovations through the regulatory process, and then they end up on the table for decision for payment. And when those payment policies do not align, federal payment policies don't align with innovations that have been approved as safe, AAKP calls that government determinants of health. Why? Because it means that ultimately you will not get access to those products, or access to those products will be a patchwork quilt of accessibility. And to medical professionals, this means that some may have a larger toolbox and access to tools that can help you, and others will not. That's disparities in care. But government determinants of health is a major issue for kidney patients, and it's one that we must unite on to fight and to encourage the federal government to come up with a more systematic and intelligent way of approaching access to therapies, access to diagnostics, and access to devices for kidney patients. Our lives depend on it. Look, we don't work for the federal government. The federal government works for us. And if we don't raise our voice and have our concerns known, they'll never know how disconnected things are, and they'll never really truly understand what the disparities in kidney care look like that we've each seen, where we get our care and what we've heard from each other.